Anyway, welcome to this morning's program, the Enos Park Access to Care Collaborative. Our special guest, I will introduce only the first one and they can go from there. Mitch Johnson is Senior Vice President and Chief Strategy Officer of the Memorial Health System. Mitch.
Thanks, Bob, and it's good to be back with you. We were here a year ago after Memorial, St. John's, and the Sangamon County Health Department collaborated to complete our first joint community health needs assessment. And at that time, we shared with you what the priorities were that came out of that. And at the end, we talked about next steps. And in particular, we focused on the Enos Park Access to Care Collaborative. So this morning, we're pleased to be back and share with you what we've accomplished in the first year, and also a few other initiatives that we want to highlight that came out of that needs assessment. So with me this morning are Kim Luz, Divisional Director of Community Outreach for HSHS St. John's Hospital and HSHS Central Illinois Division, Dr. Tracy Smith, Director of Population Health Integration and Community Health for SIU School of Medicine, and Tracy is the true champion of this Enos Park Access to Care Collaborative. We're very proud of the work her and her team are doing. Paula Gramley is Community Benefit Manager for Memorial Health System, and Gail O'Neill is Assistant Director, Sangamon County Department of Public Health. Each of them will give a brief presentation, and then we'll take questions and answers at the end. Thank you.
Good morning. My name is Kim, and again, I just thank you so much for having us here this morning. We're excited to share with you all of the work we have been doing over the last year. Right now, I just want to give you a very high-level overview of what steps have brought us to this point in time. As Mitch referenced, we came together to do a collaborative health needs assessment back in 2015. And during early on discussions, we had agreed, Memorial Medical Center and St. John's Hospital had agreed that we would identify one priority area, and we would collaborate around that area over the course of the 3-year health needs assessment cycle. After we went through our prioritization process, it became very clear that access to care was a high priority need in Sangamon County. When we sat down and looked back at the data that had led us to our top priorities, we started to look at where the most need was throughout our community for access barriers. Enos Park surfaced as one of those areas. Something that was very appealing to us about Enos Park was that they have a very established neighborhood association called the Enos Park Neighborhood Improvement Association. Michelle Higginbotham, who is here with us today, had reached out to both hospitals over the course of many years, and we had been partnering in various activities over 10, 15 plus years. And so it was just a very good next step for us to reach out to her and see if that board was interested in partnering with us to do an access to care initiative. Another thing that was very interesting about Enos Park to us is you have a neighborhood that is bookended by 2 hospitals. It sits across from SIU's federally qualified health center. And the more we learned about Enos Park neighborhood, the more we identified social service organizations and health organizations embedded within the neighborhood. Yet we still saw this access barrier. So taking off our healthcare provider hats, we decided to go into that neighborhood and do focus groups. We commissioned U of I, University of Illinois Office of Survey Research to facilitate those 4 focus groups and to analyze the 96-page transcripts that we got from those focus groups. We wanted to ask the residents of Enos Park, what are your barriers to access? So we would not be coming in with our healthcare hats and saying what we thought the barriers were. This was very much a community-driven initiative. At the end of that 96-page transcript, when we received the analysis, it was very clear that a navigation process was needed for the individuals living within Enos Park. A community health worker model is something that we desired to put in place there. When we all asked ourselves, who do we know in this community who, as Mitch likes to say, we will forget more than this individual will ever know. How do you say that? She'll forget more than we will ever know about a community health worker project. So we reached out to Dr. Tracy Smith and we asked her if she would partner with us in this journey of developing a community health worker model for Enos Park. And at this time, it is my pleasure to invite her up here and let you know what has been happening over the last year, tell you a little more about the model that has been developed and some of the outcomes we have seen. Tracy?
Thank you very much. I wanted to point out that sitting on your seat, there is an infographic which kind of highlights some of the key information that we wanted to share with you. There'll be more information that will be shared through the slides. And then also, if anyone is interested in more information, we do have a handout that will be at the back, which is our impact statement, which has all of the information that's included in here, plus some other information for you. So thank you very much, and thank you for inviting me to be part of this project. And I just want to point out that I always talk about health, and I don't talk about just necessary access to care. So you'll see me always talking about access to health, because health is so big and is really the root that makes the change in everything we do. I also want to point out that I'm really just the storyteller today. I'm not the person who wrote this story. The residents of Enos, the community health workers, the school in Enos, the churches in Enos, and the service agencies are the ones who really put this story together. And I'm just really fortunate to be the person who can share that with you. And most of this has already been covered. As we said, really it came out of the Community Needs Assessment in 2015 to really address access to care. And the question we had to ask was how to address this and where. And as Kim did so well, she explained to you why we chose community health workers. It is a best practice that shows improvement in access to care, and why the Enos neighborhood. You know, it's basically we looked out our windows and we said, if we can't address care in this area, how can we say we can address care across town? And so that's where we started. By definition, a community health worker is someone who has a frontline public health worker who's a trusted member and or has a close understanding of the community served. And as I introduce the 3 community health workers that we hired through this program, you'll understand how they are a trusted member and exactly how they have a close understanding of how the community works. But before we do that, I want you all to close your eyes, and I'm going to read to you a couple quotes from some of the clients and the service agencies that we've worked with. And again, I ask you to close your eyes because I want you just to kind of listen to the words that they shared with us. So the first one said, I'm missing a mom, and having someone to call and double check on me kind of helps, you know? Part of the whole goal of the Enos project was to develop and decrease isolation of individuals. We know from literature that isolation leads to decreased health, decreased access. And if we could create a system that decreases isolation, we could do that. And that's exactly what that first quote says to me. So again, let's listen to the second quote. Go ahead and close your eyes. I work at a homeless shelter at Inner City Mission. Shelley, who's one of the community health workers, came in and was offering services to our residents. One of the things Shelley did was helped our residents find a family doctor. So the second thing we know from best practices is that having a primary care provider or a medical home leads to the best access and leads to health. And that's exactly what our major project focus was through this. And then finally, again, close your eyes. Getting off the medical card is stressful and it's overwhelming. Not that you want to depend on the government for your lifespan, but the transition. Without that kind of help, I think it's very difficult. And this, to me, summarizes everything. We want to help people become independent. We want to help them be able to navigate the system down the road by themselves. And this quote says that we were successful this year. So we've already talked about Enos Park. We know that it has about a census of 2,300 folks. And there is some poverty concerns in the area. And for us, we focused on the area between Rutledge and 9th Street and Carpenter and North Grand. And here is the heart of the whole project. The 3 community health workers that we hired over this last year, and they're not with us. 2 of them are not with us. One of them is today, and she's no longer a community health worker, but I'll explain why. But the other 2 are currently driving patients to the doctor's office for a clinic that we started this morning, so they could not be here. But Shirley Thompson is the first person who is here, and Shirley is just a wealth of information and a wealth of love. And she comes with her background of a lived experience. She grew up in the projects in Chicago and moved to Springfield and worked her way through college. I was lucky enough to know Shirley from some of the work I had did in the community, and whenever the budgets got cut, she had lost her job, and she reached out to me, and it was perfect timing, and she came in, and so her lived experience has really brought a lot to the program. The second individual that is pictured here is Shelley Weatherholt. Shelley is a social worker who had gotten burnt out and took some time off, and came to me through this project, and I am so glad that she came back into social work. She was looking for something that really helped her to see an end result, and she says she's found it with this position. Shelley grew up as a single mom with 2 young boys that she worked many jobs to try to put the food on the table and a roof over their head. And so that lived experience goes a long way. And then Dawn, and Dawn is with us today. Dawn came on as kind of our community expert. She lives in the Enos neighborhood, and she has built a world of programs and just community relations for us. Now, Dawn no longer works with us. She received a job at the McLernan School, which is the neighborhood school, as the parent educator. And that has just is a relationship that we really were fostering and working on. So that is just a success out of this project also, of Dawn being able to move into that role. And again, they focused on creating trust. And people always ask us, where are clients coming from that are in the program? We are getting referrals from everywhere, from the churches. There's some wonderful churches that are connected to the Enos neighborhood. Service agencies, neighbors. People themselves are calling us. The school, a lot of the self-referred. It's just amazing the number of referrals that are coming in. So, you may ask, who have the community health workers reached? Well, this year they worked with 111 residents that they enrolled into their complete community health service programs. We also developed a bike club, and Dawn was really the leader of this, along with our neighborhood police officers. And we had 19 kids that completed that bike club. We had 27 kids that went through a summer enrichment program that Dawn helped to create too. And that summer enrichment program had things all the way from healthcare, learning about healthcare careers, to learning how to cook, to doing all kinds of amazing things. We have reached 560 other individuals in that neighborhood through other community outreach activities. And we've had 28 residents through Memorial Behavioral Health Mosaic program that have been either referrals from them or referrals from us, so that we can help individuals to get to some of those behavioral health supports that they need. We've had 15 students that were also educated by our community health workers. So these are healthcare students, whether they're physicians, nursing students. I've had some business students have gone through the program to see how do we look at fiscal spending, those types of things. So we've also created a center for education. And we've been involved with 40 community agencies at least. And so I appreciate all their support. So what have the community health workers did? So as I told you, one of our major goals was to decrease isolation. And they have done this by spending over 41,000 minutes with clients in face-to-face time and 685 hours. They've reached a diverse population, as you can see there. And we've also reached 2 special populations that we didn't necessarily go out and intend to, but we're so excited. We've worked with 26 people who were parolees. There are some halfway houses that surround the perimeters of Enos. And there's 15 people who were homeless that were within the Enos neighborhood that we worked with. So what else have they done? They've done 25 referrals to substance abuse assistance. We're excited. One of our ladies we've worked with just celebrated her 4th month without a drink, and she came and spoke to the medical students about that experience, and so we were so excited for her to be able to share that back. We've had 19 patients that got into the dentist with 40 cavities addressed in those 19 individuals, and 7 of them ended up having full dental extractions. And this was a huge thing we wanted to look at because we constantly hear the concerns about getting into dental care. We had 121 encounters with patients to address housing, 151 social service agency referrals that we completed. We were able to find 10 folks who were veterans who were not getting the benefits that they deserved, and we were able to help them get the benefits that they deserve so rightly. Also, Shirley and Shelley have done 983 transportation trips. So their little wheels are just burning the roads out there. And, but this is so important because we know transportation is a major barrier. And I had asked Shirley and Shelley, I said, oh, you're spending a lot of time doing that. Maybe I should just get a van or something to do that. And they're like, no, this is our special time with our clients. We get to know them really well this way. This is when we share a lot of conversation. So they do not want to give up those transportation trips. We had 65 clients that established with a primary care provider. 290 trips to the physician. So Shirley and Shelley would attend physician visits with patients, often to be an advocate or to help explain their life circumstances to the provider they were seeing. Also, Shirley and Shelley completed, and Dawn completed over 150 hours of training so that they would have the skills to be able to lead individuals to the best areas of their health. And amazingly, we were able to capture over $50,000 worth of income through disability or reinstatement of retirement benefits. And that's $50,000 that can come back into the community to help with housing, to help with food, and to help services that otherwise they would have needed be able to help more folks. So what about the clients themselves? So we connected into a database that's used here in Springfield by many of the agencies that have some housing funding. And this is a national system that kind of tracks things like employment, income, et cetera, the things that you see up here. And we use that because that allows us to look at how are we doing in comparison with other agencies in the area. And as you can see, we addressed employment, income, food and nutrition, healthcare coverage, life skills, mobility, and community involvement, which is a huge one for us. We really want to make this a community program so that that is sustainable then. And it doesn't take a lot of funds to do that once the community takes it over for those purposes. This community involvement was shown by them coming to help distribute food at food pantries, by coming and speaking to my med students about things, to going to a coffee shop hour with some of the other folks in the area. Dawn was just sharing a story with me about a mother that's single that also took another mother to the food pantry. She picked her up and took her along. Those are all community involvement, and those are the things that we really want to see. And then physical health, you may say, why only 25%? Isn't the focus on this on health? Well, unfortunately, the way that a lot of national places measure health is that their health becomes what we call healthy, right? They have no more disease processes, they're not dying, or those types of things. I'll tell you that many of the folks that we've worked with, in fact, 3 individuals we picked up had end of life. They were at the end of their life. The goal was then to make that end of the life experience comfortable for them. When we measure that according to national standards, that doesn't show that we improved health. Okay, but in my mind, we improved their health dramatically. They were able to pass away at peace, without pain, and in the way that they preferred to. So one of the big things, as we discussed, was increasing access. 100% of our clients have insurance now, and that is an increase of 56%. 35% reduction in unnecessary emergency department visits, and this is really important. What we find for a lot of individuals who go to the emergency department all the time, they're not getting better. This is not the place for them to get better. And so we need to redirect them to a home that helps them to get better, and that's what a primary care home does. And by doing that, we were able to decrease that emergency department visit by 35%. And 100% of them were selected a primary care home, and that was increased to 51%. So we did have 409 primary care provider appointments that were made during this time, so that is access. That is key. 96% of our patients saw a primary care provider at least once in the year. We had an 83% show rate. And for those of you who don't know what that means that our patients showed up 83% of the time when we made appointments for them. And this is really important. What we often see happening is that nationally there is show rates anywhere from 25 to 65% out there when you estimate it. So when someone doesn't show up for their doctor's appointment, first of all, they're not getting the care that they need. Second of all, that appointment is not available for someone else to get. And that decreases access. And so by having a high show rate, we were able to make sure people were getting in, and that we weren't having an appointment that was open that someone else could use. So that led to a 17% no-show rate. But when we looked at the data, and this is what's so important about collecting this information and looking at the data, we found that 35% of our show rates were from 2 clients. And there were 2 clients that we had really not engaged in getting them to their appointments. One of them was just a referral to us because she was elderly and needed an air conditioner in her window when it was so hot this summer, and we worked with her on a very limited basis. And so now we can make sure that we're focusing with that individual to see what can we do to help them get the care that they need. So how did the access to a medical home, though, affect their care, their health? Because that's really the true question. We did not have any kids in our program that were excluded from school on the first day of school. And I'm sure that most of you have seen that in the paper, and that was concerns that was discussed. So 43% of our kids needed immunizations or a school physical to get back into school. And all of our kids had that on the first day of school. 76% of our our patients have received a depression screen, which nationally is anywhere from 50 to 60% of folks. 94% had blood pressures that were within recommended levels. We were able to help identify 4 new folks struggling with diabetes. And again, like I said, we helped people through the end of their life treatments and give them support. And we were able to get 44 people mental health services that they were not able to get into before. So one of the other big things I've talked about is we wanted to connect to the community. And I really do believe that we've started to do that. We created a community advisory group, which is 14 members, and we had 11 meetings, and this is residents of Enos neighborhood. They're on the advisory group, and I think some of them don't even know they're really on an advisory group. They know they just come to a meeting and we talk about this. But we did a lot of focus, and I'll get you there any way I can. We focused on safety and engagement with McLernan, and so that's why it's so exciting that Dawn now is in the position that she is. But they also developed a mature club where individuals in the neighborhood that are over the age of 55 or so meet for coffee. And this was something that was a concern, that there wasn't really a site for them to get together. I've talked about some of these other programs. Dawn was sharing some information with me about the library. In the past, the library did not have enough volunteers to be open all the time, like they wanted to with their hours. And there was maybe, 10 kids showing up, 10 to 15 kids. And now this last time you said now there's up to 5 volunteers, and so they've not had to close for lack of volunteers. And you had 30 kids the other day show up, 33 the other day. So this is really exciting. And there's a whole bunch of other things that are being addressed through them. We also wanted to connect to the provider services in the area. And so we have 12 members who've attended 5 meetings, and we have provided them with different trainings. And everybody seems to be very satisfied. My time's up, but we're going to go on for just another second. Very satisfied with the outcomes of this. Again, the Advisory Coalition, if you look at this satisfaction survey, a lot of them said, I don't think I've been involved in it, but they're there every time, so I just probably haven't told them they're involved. That's my fault. So what are the discoveries that are good? We've identified some new partners. The neighborhood police officers are wonderful people for us to work with. They led our whole bike program that the kids were involved with, and this is exciting. We're hoping that we can continue that conversation into other places. We've looked at some models for housing. We worked with the neighborhood association with 6 units in the neighborhood, and that has resulted in an 89% reduction in police calls to those units. Our recidivism rate for those who are parolees is 19% versus 56.7% annually, nationally. And we've just done that by making sure they can get jobs and get housing. And we've looked at some systems changes. We've created some new care clinics at our offices so that patients can get in easier. We've also addressed some different policy changes in the area. And there's been requests to expand this program, and we've been able to, through another support system, get some United Way funding for Brandon Court to start a community health worker program there. So what has been challenging? The need is so great. We have had to shut off recruitment. I mean, we just can't take new patients right now. Our data access is complicated, and trying to figure out what is the best data system for that is very difficult. We know there's a very high transient nature of folks who are struggling to make contacts. There's a lack of housing and employment support programs, and it's often difficult to engage the youth, but we're working on those things. So in conclusion, I just want to say that the joint effort of the 2 hospitals in Springfield is commendable. And I really do thank them for leading this great initiative. We know that access has really increased, but we still have a lot of need to go. We need to improve health by addressing unemployment, poverty, and education. And so basically I challenge everyone in this room to think of what you can do collectively in the future to assure that the conditions people live in allow them to be healthy. And this is a list of the partners, and I hope that I got everybody up there, and if I didn't, I apologize. And so I'm going to turn this over now. Is it Paula that comes up now, or Kim? Okay, I'm going to turn it back to Kim. Thank you.
Well, I had to be Tracy's timekeeper. I did not enjoy telling her when she had 1 minute left. We could listen to the outcomes of this project all day long. She's done exceptional work, so thank you. At the last health needs assessment, St. John's Hospital identified 4 priorities. Our priorities were obesity, mental health, pediatric asthma, and of course, access to care. So I'd like to spend just about 5 minutes and tell you about what we have done over the last year with our pediatric asthma initiative. What is the problem? You know, as I said, we looked at endless data to identify our top priorities. One of the things we found is that IDPH lists Sangamon County as one of 8 worst counties in asthma hospitalization rates for the state. The recent health needs assessment identified pediatric asthma as a health disparity, specifically in low-income zip codes in Sangamon County. The rate of emergency department use and hospitalization is increased for these zip codes, and the numbers are staggering. In our lowest income zip codes, we see we have 247 pediatric asthma-related emergency department visits per 10,000 individuals. In our highest income zip codes, we see that rate decreases to 16.6. So for our lowest income children, they are 15 times more likely to end up in our emergency department repeatedly for uncontrolled asthma. So some of the long-term impacts of this uncontrolled asthma is obesity as you grow up, pneumonia, learning disabilities, poor focused attention and concentration, and we know that that greatly impacts scholastic achievement and long-term professional gain. You're at a greater risk for depression and poor long-term health function. These are just a few of the long-term outcomes from uncontrolled asthma. The most important part of managing asthma, and this is the bigger picture that we all need to realize, this is also the exciting piece. It is not a scientific equation. The most important part of managing asthma is for the parent or the guardian and the child to be knowledgeable about their triggers and about prevention and management strategies. It's all about education. So we launched a pediatric asthma initiative. I'm going to go over some of our partners in a moment. When I say we launched, it was not St. John's alone. I want to point that out. We have an asthma coalition that I'll talk about. We're using a population-based approach. We are doing a pediatric asthma trigger reduction initiative. And then I'm going to let you know, I have up here fiscal year 17 progress, but it's really the progress we've made in fiscal year 16 and leading into fiscal year 17. Our asthma coalition consists of myself and my outreach facilitator, Megan Williams, who was going to try to make it. She had another meeting. And then we also have our partners from SIU Healthcare Department of Medical Humanities. I want to point out that SIU had received an asthma champion designation, and that designation was instrumental to starting this asthma coalition and really giving us a strong foundation from which to launch these initiatives. From there, we have Carestine, who is no longer with SIU. However, she represents the data analysis component of this coalition. Carolyn Pointer, who is in the room, so I'll point her out. She's sitting right up here. Dr. Samir Vora, who is a pediatrician. Our community partners are Springfield Community Federation, and this is a small nonprofit organization that is located within Brandon Court on our east side of town. The Springfield Urban League, and then our funders are HSHS St. John's Hospital, and with SIU's designation as asthma champions, we were able to bring on the Illinois Department of Public Health as another funder in this process. So what is a population-based approach? Really, we decided to focus on a geographic population. We analyzed 3 years of local hospitalization and emergency department data to show us where the largest area of need was in our community. We developed heat maps to narrow incidence by location. We looked at rural versus urban. There's so much talk about, because we're in a more urban setting, a lot of our resources sometimes feel like they go to an urban population. So we analyzed, do we need to focus efforts more on rural or more on urban? And we identified, at the end of the day, Brandon Court and Poplar Place as our hotspots. Here's a heat map that shows you where the concentration of pediatric asthma patients, those are individuals 18 and younger, by hospitalization rates throughout the county. And then when we look at specifically the urban areas, you'll see the area to the north of the Lincoln Home National Historic Site. That's our Enos Park area, pretty much. When we looked at that area, we are pulling more of our middle school and high school aged individuals. We decided we really wanted to focus on those 0 to 5 years old. And these bright red spots that are in the lower corner, those represent our east side of town, specifically around the Brandon Court and Poplar Place, and that is where the majority of our 0 to 5 year old children are coming from with uncontrolled pediatric asthma. So we focused on our geographic location, and then we engaged partners in multiple sectors to really have this collective impact type approach. I'm not going to read through this list, but you can read through this list as I am going on. We used the data to measure, we will use data out of the initiative that we have launched to measure progress, to improve interventions, and advocate for new reimbursement models. Ideally, we are working toward financial sustainability. Right now, I told you who our two funding partners are for the next 3 years, but we would like to see this a sustainable model that we can also increase and enhance throughout Sangamon County. The trigger reduction program that we have put into place, I'm going to go through these steps with you very quickly. First and foremost, you've heard a lot about community health workers today. We identified community health workers. Our community health workers are actually individuals who live within Enos Park. Enos Park, no they're not. They're individuals who live within Brandon Court and on the east side of town. We trained them. We had Dr. Kramer from St. Louis University. He has written the book on home assessments and trigger reduction plans. He has studied this for over 25 years. He has national best practices. We invited him to train our 3 community health workers. We then did outreach to identify families in need. It was just basic surveying, going in. One of the things to note is that asthma is not always a diagnosis, but we still know that there are breathing problems and there are environmental triggers leading to those breathing problems, even if your child has not been diagnosed with asthma. So we wanted to make sure that we weren't using that diagnosis to label which families we would work with and which families we would not. Our first visit was to really engage the family and start building those relationships with the community health workers. Our second visit is to do the home assessment. They go in, we bought them all sorts of equipment. They kind of remind me of Ghostbusters after that movie came out. They have all their equipment and they have lots of lights and noises. So they go around the house and they go in and they search each and every room for different triggers that might enhance the pediatric asthma situations. On the third visit, they go over the trigger reduction plan with the family. And a lot of times that comes with it mattress pad covers, dust mite, air purifiers. We have vacuums and other things that we will give the family to help keep their house clean and reduce those asthma attacks. Then we do a follow-up visit. We do several follow-up visits to measure the impact of this trigger reduction plan. We will eventually evaluate emergency department and hospitalization usage and then use that information and outcome data once again to advocate for the policy, system, and environmental changes. So this, in a nutshell, is the initiative that we have launched. Our year one process, once again, year one progress rather, we have created our asthma coalition. We have done the asthma home assessment and the mitigation plan training. I was told not to use mitigation plan, sorry, it's a trigger reduction plan training. We have done our community health worker training. We have gone through our IRB study review. We want to use this next 4 months as a case study so that we can say, yes, we have proven that this is going to be effective, and then we can open that up to receive additional funding to make the case for possibly home assessments to be reimbursable, and then to do this in other locations of town. We've done community engagement. That was the biggest thing, and you heard Tracy talk about that a lot, is engaging the community and being seen as a respected partner to help improve health in the long run. We've done some community health worker activities, and to date, we have done 12 home assessments and 12 mitigation plans. The future of this program, moving on in the next year, again, we really want to work on sustainability, a business case for home assessments. We want to eventually work with schools because we know that kids are missing a lot of school days because of asthma attacks. Decreased school days is going to lead to decreased scholastic achievement. So we really want to give kids a healthy start to their life. And then we want to advocate to improve policies that impede asthma control. And one thing that's not on here, you will see when Gail O'Neill comes up from the health department, is that they have also identified asthma. So once we see our best practices, we really want to work with their individuals who go into the homes to teach them how to do home assessments and train them on the trigger reduction plan as well. And then to leave you, I just have some pictures. I always love pictures of some of our kiddos from Brandon Court. We brought them into the hospital and we have been doing hospital tours with them. This was part of our summer outreach and community engagement program. And you'll see this last slide here shows our teddy bear clinic. We brought them in, they each got a lab coat that said future doctor. Or honorary doctor rather. They each got a stethoscope, which I thought was really cute. They wore them around their necks until Dr. Mander, in this top right picture, he is our chief medical officer. He came in with his stethoscope folded in his pocket. So after that, each one of these kids had their stethoscope folded in their pocket. And it's a good thing he was there because at one point he helped a child resuscitate one of their buddy dolls. It was a very scary moment, touch and go there for a while. We taught them about CPR and we taught them about AED machines. They toured our Prairie Heart Institute, and then they also toured our simulation lab. You can see one of our young individuals there scrubbing in, getting ready to go check out our Stan mannequin. So this is just some pictures of one of the things we did for community outreach. And with that, I'm going to invite Paula up.
Well, this is, well, I'm going to talk about mental health first aid, and this is one of the initiatives that Memorial focused on coming out of the Community Health Need Assessment. And it is a collaborative initiative with our health system, Memorial Medical Center. We have hospitals in 3 rural counties. Passivant is in Morgan County, Abraham Lincoln Memorial Hospital in Logan County, and Taylorville Memorial Hospital in Christian County, and then Memorial Behavioral Health, which had a name change this past year. You may be more familiar with it as Mental Health Centers of Central Illinois. It's now Memorial Behavioral Health. So coming out of the Community Health Need Assessment, we had a lot of data to show that mental health is an issue locally. And here in Sangamon County with the need assessment, when we did the community survey, mental health actually ended up being the top need identified out of that. We had indicators for all 4 of the counties where there are Memorial Health System hospitals. All 4 counties identified mental health as an issue. So we took a step back and we said, what could we do possibly as a health system initiative to impact mental health issues in the 4 counties? And we convened an internal focus group and looked at that. And the issues for all of the counties were not identical, and the resources for all of the counties were not identical. But we were trying to identify, was there one program, one initiative that we could do that might help impact the region? And Memorial Behavioral Health suggested mental health first aid. And this is a program that is designed to help communities. It's a national program. It's evidence-based. It's been endorsed by SAMHSA, Substance Abuse and Mental Health Services Administration. There is a big push this past year and this coming year to really, really get this program embedded nationally into communities. And so when this program is taken into communities, community members attend an 8-hour training session. And at the end of that, they're considered first aiders, kind of like you might take a first aid course from the Red Cross. Mental health first aid is a focus on mental health first aid issues. And like learning CPR to help somebody who might have a heart attack until professional help arrives, mental health first aid gives the community members tools to understand mental health better and how to help get those people to the resources that they need. So why might this be a good approach? Mental health problems are extremely common, and mental health first aid helps a community member notice when an issue is going on. Sometimes it may seem the norm and we may not notice that something is an issue, so it raises awareness. There's a lot of stigma and shame and embarrassment sometimes associated with mental health issues. And mental health first aid helps community members understand mental health better and therefore promotes understanding in the community. Professional help isn't always available when somebody needs help, when somebody is depressed or in a crisis situation. And the more community members know about mental health and the issues affecting it, the more they can come around a person who is affected and help them and supply understanding and support. People with mental health issues often don't go for help. They may not realize that they need help. They may be ashamed. They may not know where to go. And mental health first aid helps educate a community about the kind of help that is available in a community and how to address people get those people to the resources. Finally, many people aren't real well informed. Many of us in the community aren't real well informed about mental health. And if we see somebody struggling with an issue, we may be afraid to go up and say, do you need help? Is there something I can do to help you? Because what if that person says yes? Then what do? I don't have resources. I don't know what to do if that person says yes, they need help. I'm floundering. I don't know what's available. So mental health first aid gives community members a tool to help understand what is available in a community and what steps they might be able to take to intervene to head off some of the issues that could develop into a crisis. And it could possibly even save a life down the road. So mental health first aid is a program to equip communities. And people who take this course learn risk factors and warning signs of mental health and substance abuse issues. They learn about depression, anxiety, trauma, psychosis, substance abuse. They learn a 5-step action plan that they can go through step by step and try to help a person who is developing a mental health problem or is actually in a crisis situation. And then they learn about available resources, evidence-based resources, both that are in the community, peer supports, self-help resources that are out there. So there is an additional component besides the mental health first aid. There's a special course called Youth Mental Health First Aid. That's a different training set, and it addresses the unique risk factors that children, youth, ages 12 to 18 face, such as anxiety, depression, psychosis, eating disorders, ADHD, disruptive behavior, and substance use. So this program, again, helps community members learn a 5-step action plan to help youth who may be having issues. So who in our community could benefit from this type of training? Well, police departments, fire departments, ambulance, any first responders to a situation. Schools, colleges, staff on those areas, coaches, youth leaders in different programs all across the community. Our faith and faith community, churches, youth pastors, caretakers, anyone who is in a caretaking role, nursing homes. Chamber of Commerce, businesses, HR professionals. Mental health issues are very common. The estimate is 1 in 5 adults struggle with issues. So that affects our business community, and you could help equip your business or your HR staff with how to help somebody coming in that has issues. Professional organizations or service organizations in the community might be interested in this education. And then anyone in the community at large, anyone that wants to learn more about mental health or substance abuse. So if this program is something that's recommended nationally for community members, how do we get the program into the community? We have to have certified trainers. The program is only offered through somebody who has certification to train and teach the program. And so we decided that we wanted to get certified trainers in the 4 counties where Memorial Hospitals are. And mental health first aid training is expensive. So when we looked into all the options, we found that it was a lot more cost effective to bring the national trainers to Springfield to train people, and we could train a lot more people for the cost of sending a handful of people away to Washington, D.C. to get this education. So Memorial trained to have those, Memorial paid and covered the expenses to have that training come to Springfield. So we collaborated with a number of local community organizations and asked them if they would partner with us and get some of their staff to become certified trainers to offer this community mushrooming out into the community. And we had just a tremendous response from community organizations. And 27 people did receive this training here in Springfield from April 1st to 5th. And it was a week-long training. It wasn't lighthearted training. The people that took the training had to complete a big application to even become a certified trainer, had to pass that. They had to take 5 days of training, and they've had to pass an examination at the end to get their certification. So it was a big commitment on the part of these organizations to allow their staff to take 5 days off of their normal assigned responsibilities and come to this course. Then 20 of those people returned again in September for 2.5 more days of training to get the additional certification to be youth mental health first aid providers. So this is a list of the organizations here in Sangamon County. We have additional groups in Morgan, Logan, and Christian counties that also sent people. You'll see the first 3 groups up here are the Health Department, St. John's, and SIU, who are our partners in our other collaborative issues that we've been working on. We had the school district, the Urban League, U of I, Community Connection Point, Lincoln Prairie Behavioral Health, Phoenix Center, and Memorial Behavioral Health. And we want to thank our community groups that made this large commitment on the part of their staff. So if a community member wants to take the training, what does that involve? Training is an 8-hour course for either the youth mental health or the adult mental health. You can take it as a 1-day course or 2 4-hour sessions. And all of those people that got training are donating their time. Those organizations are donating their staff time to go back out and help with this community training. So we are able to offer this to our community at the cost of only $8 a person, which covers the cost of the training materials from the national program. So it's very, very inexpensive. That training cost may go up in the future, but that's what the program materials are costing us at this time. Depending on whoever is hosting the event, there may be an additional fee if that organization needs to charge people for lunch. So that will vary from course to course, but the overall cost is really just $8. So, call to action for you, members of the community. What can you do to help get this information into our community and into our community members? You may want to offer this training for your organization, whatever organizations you are connected to. You may know groups that would benefit from this. We also need organizations to host community training at large where we could just open it up, say this training is available, anybody that wants to attend can come. So Heather, would you stand up? Heather Sweet from Memorial Behavioral Health is here. Stand up so we can see you. Yeah. Heather has information in her contact information. If you're interested in mental health first aid, Heather is with Memorial Behavioral Health. She's also in charge of the Mosaic Project. Heather is our contact to help coordinate this. And as training dates become available in the future, we're going to be offering those at the website, and that's how people will sign up for this. Some of the trainings may be closed if it's for just one particular organization. Others will be open. So we're just now starting to roll this out, and we need your help to help us get word out about this. So thank you. Gail O'Neill is going to update on some of the I-Plan.
Step one, gracefully get up to the podium. I'm Gail O'Neill. Our Board of Health, you've heard all about the assessments, identified 3 priority areas. Our process is a little different than the hospitals need to go through, but we need to come up with 3 priorities and work to see that work's being done in the community and that we're having some improvement, whether we directly are involved or just try to help support the community and the issues. See, all these problems that you've been hearing about are quite big and not easy to solve, or they would have been solved by now. And so in the area of child abuse, our board felt it was a very important issue and really hard to solve. So in our area, you know, the nurses are mandated reporters, and that's kind of an after the fact. They undress children to weigh and measure them and those kind of things, and may see indications of child abuse or neglect. They may go into the home, so we have opportunities to do that, but it's kind of after the fact, and we're hoping that, you know, there could be an intervention. Like the community workers, we have programs that take us into the homes of women and children most in need. One of the programs that we're kind of retooling right now to help with this is called Healthy Families Illinois. Healthy Families is kind of a program you find throughout the country that starts, instead of an intervention program, as a prevention program. So it's in-home parenting, starting with birth of child to age 3. Our program was previously run with some community workers, more on a lay program. In the last year or 2, we've tried to retool that and bring on nurses to focus in this area, work in conjunction with the community health workers, and to do some really good parenting education of the kids. It's a risk factor-based program starting at 3 months. So currently we're starting the process to hire 2 nurses to do that and hope to have 5 by the end of the year. This whole process got a little slowed down last year with the budget impasse, and we're hoping that that doesn't slow us down this year because we're ready to go. We know it's a big problem. The access to care is a problem we're working on all together. One of the things that we do, it's kind of required by all our grants and our various programs, but we try to make sure that the clients, anybody that comes to us for services, we're not primary care. We help with immunizations, we help with WIC, and it leads people into other programs. But we try to make sure that everyone that comes in knows who their primary care doctor is, knows the importance of having one, and getting them to the doctor for care during the year. So we're just there to fill in the gaps, mostly with immunizations if they're unavailable to them. Especially with the WIC and the family case management clients, a lot of people don't know they're assigned a doctor, and we try to make sure they know that they're assigned and send letters, send information and lists back to the doctors, and try to make sure that we facilitate people having access to care. The third area is pediatric asthma. As Kim said, we're looking forward to some training for ourselves. Interesting, the triggers that you learn about. We'll train our nurses, especially each of our programs does go in the homes and might be able to help support. When they were talking, our staff easily picked up on, okay, so the cheapest things to clean with are ammonia and bleach, and those 2 put together are a bad thing right away. Simple things like that are messages that could easily be spread from the nurse to the family in just a short time might help prevent and might have a lot of impact on the asthma problems that we're seeing in the community. The board also wanted to pick a couple strategic initiatives. It's a term that they use at the state for us to say there's something else that's really important. It's kind of interesting they are insistent on addressing, and it's important, infant mortality and maternal health. The numbers of infants that die in the first year has greatly reduced over the years, almost to a low number. But as anybody feels, one is too many. Some of them are born way younger and are saved. So our programs still, we have some that are working quite well and doing good. One that you may not know about is Better Birth Outcomes. It's BBO. We have a nurse that works specifically with high-risk infants, pregnant women, or the pregnant women that might need some help making sure they make their appointments. They're referred by physicians. They actually have one of the nurses that goes over and works with Dr. Yonkin's office and makes sure that if there's some that aren't doing for whatever reason, getting to their appointments they need to, that she will, weekly go visit her, monthly, and to make sure that those kind of things happen. And the chronic problem that we have with our numbers is sexually transmitted infections. We are one of the highest in the state for having youth and minority youth having a high rate of sexually transmitted infections. We've pulled together some community groups in the last year trying to see what we can do to reduce the number of infections that are happening and the reinfection, and make sure that the youth and the community and anybody that comes in contact with youth can try to improve this number of people becoming infected. The community groups are doing that. We'll probably continue to battle that and look for any kind of, one of the things is the schools. We're doing a lot of education in the schools and being pretty specific with talking about sexually transmitted infections and disease. So we're hoping that we see some improvement and look for any community involvement that we can. I want to be quick, everything's so exciting. And ours are, so I wanted to leave time for questions. So if we have any questions, might have Tracy or who wants to facilitate questions? Are there any? Okay. I don't know if you want that back on for light, maybe.
No, it's okay. So we've just shared a few highlights given the time this morning. There's a lot more going on, but are there any questions about the initiatives we've talked about this morning? Bob, do we have time for a couple? You bet. Okay.
Are we making any headway? When we had the lady from Wisconsin come down, we talked about Sangamon County having great medical care, but rating very poorly as far as the health, perhaps, of the people in the county. Are we making some headway on those kind of numbers?
So yes, we're ranked, I think it's Carolyn, are you in here? It's 62 now that we're ranked, right? Versus we were 76 before or something? 62 or 68. Somewhere. We did move up in this last county health rankings. We didn't move up, like jump to the top, but we still stayed #1 for provision of care, but we did move up into the 60s for that number. So I think that a lot of the initiatives that you're seeing, the collaborative actions that are being done is what will move that health dial, and I think that we're all moving in the right direction to get to there.
I'd like to add to that, it can take 5, 8, 10 years to move some of those indicators. I think we're starting the groundwork and moving that direction, but we may not see that for quite a while to really get an increase.
And the key thing for us from her presentation was that we keep that forefront in our mind as we're building new programs and we're looking at new initiatives and collaborating. So I think that's really key.
John?
So it seemed like a couple of years ago when the groups got together to do that planning collaboratively, that seemed to be a big deal. You know, it had maybe never happened before, and yada, yada. Do these kind of things help people work together to make that just kind of, this is the way we do business now?
Yes, I do. I think that the biggest thing is communication. And so that was really an avenue for us to communicate and to speak the same language with each other. And I think that is what really is important. So yes, I think we can all say we collaborated in the past, but our whole level of collaboration has grown tremendously. And as I've traveled nationwide to different presentations, different educational sessions, what we're doing is really, at a forward direction. There are some places that are doing more forward direction work, but we are really doing good for a community of our size and really taking that the next step.
And I'll add to that, we identified access to care as the area that we would intentionally collaborate around. But as Paula mentioned with the mental health first aid, St. John's has a trained facilitator for the mental health first aid. So now more often than not, when we are launching new initiatives or when we are having discussions about certain issues in the community, we come together and we work around the table. And that is a huge impact in our community. Anytime we are not using competing resources, but we are using combined resources, we are able to touch more individuals. So I think this is something that has grown out of the step that we took to say we're going to collaborate around the health needs assessment back in 2015.
And I would also say that's a very good point, and the answer is yes. And it's not just the hospitals and the health department and the medical school. There are more and more partners that are coming forward. And I've been working in this area for many years, and one thing that I've really learned in the last year or two is some of these problems are so systemic and so difficult that our hospital cannot solve them, even if we wanted to. So there are others that bring resources and insights to the table, and it takes all of us working together. One great example is the police department in Enos Park and the partnership between them and the community health workers. We didn't really anticipate or understand the significance of that, but if you think about a law enforcement officer being called to a home and there's a mental health issue, in the past, maybe all they could do is take that person down to the jail. Now they can call a mental health worker and perhaps get them on site and deal with that issue there and de-escalate the issue. So there are lots of examples like that we didn't have time to go into today, but the collaboration, that is what it takes to really move the needle on these kinds of problems.
Thank you for joining us this morning.